It's an interactive session. There'll be Mentimeter used. We'll have Q&A. So please do pay attention. Without further ado, I want to just pass on the floor to my co-moderator, Nujin. Over to you.
Thank you, Pascal. It's my pleasure to be here. I'm going to introduce myself first. I'm Nujin Mustafa, a Kurd from Syria. And as you can see, I use a wheelchair. I was born with cerebral palsy. It may shock you that to know that I didn't have my wheelchair back at home. I got my first wheelchair when I first arrived in Germany. How I managed to get into Germany with a disability is a story for another time that we don't have today. Growing up, my family was always told that I needed physical therapy in order to improve the condition of my legs. There was a physical therapy center in Aleppo where we lived, but the problem is that it did not have a lift. So I had to climb up the stairs with the help of someone else. I only visited that physical therapy center in the periods of my life where it was affordable, and that wasn't always the case. Growing up, I had no conception of accessibility, inclusion, or equity. Accessibility for me meant having someone strong that would carry me down the stairs, put me in the back of a taxi, or to get me into the clinic or hospital when I got sick. What I've just described is the reality that many people with disabilities have lived through due to the lack of the inclusion of disability in the vision for healthcare systems. And I'm here today because I would like to see that changing. Enough talk about me. We have more important things to do today. Now it's my great pleasure to welcome our first speaker of the day, Dr. Ariane Hildebrand. Okay, this is going to be a mouthful. Director General for Global Health, Employment, Transformation of the Economy, Digital Technologies, Food and Nutrition Security, Federal Ministry of the Economic Cooperation and Development, BMZ. I invite you to join us on stage to give the opening statement.
Thank you, dear Najin. Thank you for your words. There cannot be more important words than what you just told us. So, don't be, there cannot be more important words than this. Thank you for this. Dear Najin, dear Pascal, thank you very much for the kind introduction and for giving me the opportunity to deliver this opening speech. And if I am too fast, please give me a sign. I will try to speak slowly, but give me a sign if it is okay. Dear participants and panelists, I would like to start by thanking the group of civil society organizations, namely the Christian Blind Mission, Special Olympics, 80 Scale, the Missing Billion Initiative, and the Clinton Health Access Initiative for bringing the often neglected topic of disability-inclusive health systems back on the agenda of this World Health Summit. I am glad that BMZ is sponsoring this session because inclusion in health is a substantial part on our path to achieve universal health coverage. We need to base our health systems on the essential needs of people living with a disability. Otherwise, we will not be able to ever reach universal health coverage. People with disabilities currently represent up to 16% of the world's population. That is 1.3 billion people worldwide. They often face more complex and urgent health needs and at the same time experience great barriers to access the care they need, and we have just heard this very impressively. It is an unacceptable reality that even today, people with disabilities live 10 to 20 years less. And it's crucial to recognize that these lives are not cut short because of the disabilities themselves. They are cut short due to limited access to solid healthcare systems. And thank you. This is a reality that we cannot accept. Therefore, I'm very happy that today we are raising awareness and are discussing with stakeholders from different sectors how we can make health systems more inclusive. Let's acknowledge a challenging reality. Our efforts towards achieving the SDGs are still not sufficient. This is also caused by our insufficient ability to fully integrate activities that address the needs of people with disabilities. Now, a few words about the role of my ministry with a very long name. BMZ is easier to remember. Germany is already a major contributor to global health efforts. We investigate significantly in building strong and resilient health systems worldwide. And we will intensify our efforts in designing disability-inclusive health systems even more. In the beginning of next year, we will include a marker, a so-called marker, for disability-inclusive projects in German development cooperation. This sounds technical, but it is an important tool that will enhance our ability to monitor and evaluate our projects, ensuring they are inclusive in all their different dimensions. Ladies and gentlemen, the high-level meeting on universal health coverage and the corresponding political declaration at the United Nations General Assembly in September renewed our commitment to global action. The new political declaration marks important steps forward when compared to the previous one. Let me give you 3 examples. It entails strong and clear language on health inequalities experienced by persons with disabilities. It calls to ensure availability and access to health services for all persons with disabilities. And it puts emphasis on primary health care, the need to bring health services closer to where people live and make them more affordable. It is now our shared responsibility to turn words into action. This applies to the global health community, but also to national governments and local institutions. Ladies and gentlemen, 2025 is going to be a very important year as we will come together for the Global Disability Summit. I'm proud that Germany, together with the government of Jordan and the International Disability Alliance, will host the Global Disability Summit in Berlin. And I promise you this, we will convene a powerful alliance of global, national, and regional stakeholders to create a strong momentum for disability-inclusive development and humanitarian action. And everyone, governments, civil society, private sector, academia, is invited to submit ambitious commitments for our common objective of advancing disability inclusion. Now, I would like to thank the organizing team for their great efforts to make this session truly disability inclusive. For example, by having a sign language interpreter in the room. Applause for our interpreter. Thank you. Thank you very much. This illustrates we're not only talking about inclusion, we live it. People with disability should participate in the design and monitoring of health services and programs. They should be the leading voices of their own agenda. Thank you for your attention.
Dr. Hildebrandt, thank you so much for these words. Really, really powerful statement, and your expressed commitment from Germany is really, really encouraging. And I do believe that we're seeing a growing momentum towards greater inclusion, which is very encouraging. We're going to now dive into our first interactive session. So for this, you'll need to activate your Mentimeter. So if you all have your phones or your tablet, you can access the Mentimeter. I think you've got the code on your chairs. It's up there as well. Takes a few seconds. So while you get that up and running, let me introduce the session lead for this section, Professor Hannah Cooper. Professor Cooper is the co-founder of the Missing Billion Initiative and the co-director of the International Center for Evidence in Disability at the LSTMH. Professor Cooper, the floor is yours.
So, good morning, everybody. Thank you for being here today in what we think is the first session on disability at the World Health Summit, which is very exciting. Now, as I was introduced, I'm a professor in a university, so I like data and I like tests, and I'm going to set a few for you here. So hopefully people have looked at the first question, which I'm going to read out now, which is, how many people experience disabilities in the world? So is it 1 in 6, 1 in 10, or 1 in 20? And I'm seeing the answers coming up. So this is a little bit of a test for how awake people are, and also how much people were listening in the previous sessions. I will tell you afterwards what you get if you get a good grade. And as you can see, it's 1 in 6. So the latest evidence from the WHO shows that there are 1.3 billion people with disabilities. That's 1 in 6. Now, disability is very, very diverse. It can include people with physical impairments, with hearing impairments, intellectual, sensory, psychosocial. But what binds people with disabilities is the barriers faced. The barriers faced in society, the personal barriers, the accessibility barriers, including barriers with respect to accessing healthcare, which were just described by Eugene. And because of that, it prevents people with impairments participating on an equal basis with others, so that there's exclusion. And that is why we're here today, because there are 1 in 6 people with disabilities globally, and there are widespread difficulties accessing healthcare. So, question number 2. Which of the following statements is correct? So, people with disabilities are 2 times more likely to have HIV or AIDS. 50% of people with disability cannot afford healthcare. Less than 50% of children with multiple impairments are fully vaccinated, and 10% of people with the AT have the AT they need in low-income countries. So which of those following statements are true? Are people starting to enter in? I'm going to give it a couple of minutes. We think so. Okay, well, the answer is it was a trick question, again, to see if people are awake. All of them are true. So all of those statements are true. So people with disabilities are more likely to have HIV. They're very likely to find healthcare unaffordable, and that creates barriers to accessing the care they need. So things like coverage of vaccinations are lower, coverage of family planning is lower, as well as coverage of AT. So few people, especially in low-income countries, have the AT that they need. And because of those barriers and because of the lower access to healthcare of people with disabilities, they also often experience worse outcomes. So we've seen a worse outcome in terms of HIV/AIDS, but it was also introduced earlier that the worst outcome of all, that people with disabilities have double the mortality rates of others in the population, which translates to a life expectancy gap of 10 to 20 years. And we saw that vividly during the COVID pandemic, where people with disabilities were 2 to 3 times more likely to die from COVID, but people with intellectual disabilities were up to 8 times more likely to die from COVID. So question number 3. So, unfortunately, we've had a little bit of a spoiler earlier in this answer, but The question remains, 2.5 billion people need assistive technology worldwide. Do you need assistive technology too? So is the answer yes or is the answer no? So we're seeing a lot of yeses, but quite a lot of nos. So I'm going to go on to the follow-up question, which is, do you wear glasses? And I'm going to say here glasses or contact lenses so that I can be in this group as well. So we see a greater number of people have already said that they need glasses, that's 60%, as opposed to the proportion who said that they needed AT, which was 54%. And as Pascal introduced earlier, AT, assistive technologies, is very broad. So it includes glasses, but it can also include hearing aid, wheelchairs, assistive walking devices and so on, but also things like your mobile phone, which can really help in all sorts of aspects of life. And I'm just going to illustrate how crucial AT is with a personal story from my life. So I have 3 children, and the youngest of whom has been quite slow to read. And his sisters were way ahead of him, and he wasn't reading. And we were thinking, well, he's very young, and he missed all that school because of COVID, and maybe he's not that bright, but he's terribly sweet. And we took him to be tested, and he has very poor vision. And so we got him +4 glasses, which is very high, and his life was completely transformed. So not only his reading, but his physical confidence, his playing football, his running around has vastly improved. And every morning, the first thing he does is reach for his glasses and put them on, because they're so crucial for his life. And there are so many children like him around the world who do not have those assistive devices, who don't have the glasses they need, and therefore are not learning to read. So many people with disabilities require assistive technologies, but actually it's much broader than that. And overall, we've said already that there are 1.3 billion people globally with disabilities, but 2.5 billion people who need assistive technologies if we're looking at this much broader group. And that number is really rising rapidly as the population is growing and aging. So that's why I'm representing the missing billion, which is about inclusive health and access to healthcare for people with disabilities. But we work very much in partnership and together with AT Scale because of the recognition of how critical that is for people to access not just healthcare, but to fully participate in all aspects of life. So thank you. I can say that you've passed the test, and the prize is that we can then move on to the next bits of the agenda. So thank you very much.
Thank you, Professor Cooper, for sharing this very valuable information. Data may be boring, but it's necessary and important. We will now take a few minutes for a fireside chat with Barbara Lejuvo. Barbara is a Special Olympic Health Messenger, and I'm going to ask her a few questions about her experience accessing healthcare in Zimbabwe, where she lives.
For inviting me and also giving me the opportunity to speak and also giving me the opportunity to represent my fellow athletes. The Ministry of Health has introduced the Assisted Medical Treatment Order, AMTO. AMTO is a letter given to people with disabilities and elderly people so that they can get free treatment at the government hospitals and clinics. AMTO letter is requested through the Department of Social Services, and through the Department of Social Services. When you get the AMTO letter, your health card will be stamped a red sticker. The red sticker means you will not stand in long queues and you will get fast treatment. Thank you.
Okay, this sounds like a very good example. Can you share what other changes you would make to the health services to make it even more accessible to people with disabilities?
I have 3 suggestions I would like to change in the health systems. The systems and services, the training of the health workers, and self-advocacy. The systems and services must be easier to access. With AMTO letter, you cannot, if you don't have the AMTO letter, you could not get free treatment at the hospitals. the AMTO letter is renewed every time when you get to the clinic. If AMTO letter is a reusable card, the challenges will be fewer to access the health system. There is need of training and there is need of awareness and education to people with disability and elderly people on how AMTO works.
Would you like to tell us more about the training of health workers?
The health workers must be trained on how to serve people with disabilities. It will be easier if health workers trained to work with people with disability, especially people with intellectual disability like me. In my case, I went to the clinic, and when I get with health conditions, when I get there, I was given contraceptive pills, which I did not request for. When I get home, when I get home and I told my friend, I was so confused. I couldn't go back, and I couldn't go back. I didn't have any confidence to go back and ask questions on how did you give me this contraceptive pills I did not request it for. In my story, it shows that there's need of self-advocacy. There is need of self-advocacy. Self-advocacy, it is important, and it enables people with disability to be empowered to ask questions and also included in the conversations about our health. Self-advocacy, it is also important to people with disability. Self-advocate, it is necessary for inclusive health. Thank you.
Thank you, Barbara, for your very powerful words.
Thank you, Barbara, for really those insights, and it's always so powerful and eye-opening to hear from people with lived experience what is happening on the ground. And I think your message about self-advocacy is really an important one. And as much as we need to make sure systems are working, this aspect of self-advocacy is really, really, really critical. Let's move on to the next bit of our session, which is our first panel discussion around the change that we'd like to see happen globally. And I'd like to welcome to the front of the room Dr. Alarcos Cieza, Unit Head, Blindness and Deafness Prevention, Disability and Rehabilitation at the World Health Organization, as well as Frederick Msigala, Advocacy Officer, Comprehensive Community-Based Rehabilitation, Tanzania, a CBM partner. Frederick. As we just heard from Dr. Hildebrand, just a few weeks ago, a high-level political statement was agreed in New York around universal health coverage, as well as around pandemic prevention, preparedness, and response. And the good thing about these statements is that they did include really strong words around the inclusion of people with disabilities, older people, and access to assistive technology. I'd like you to both tell us why you think this is so important and what it means for your organizations or for global health actors. Alarcos, let me turn to you first.
Okay. Thank you, Pascal, and thank you also, Nujin. Let me start why it is important, and it has been already been touched on it, but to emphasize it. The Declaration of Universal Health Coverage is telling to the world that countries will only make progress towards universal health coverage when the barriers that persons with disabilities experience are addressed. and it does not matter whether it is barriers at assessing health promotive services, preventive services, treatment, rehabilitation, or palliation. So it is really a requirement that those barriers are addressed in order to progress towards universal health coverage. If we look at the Declaration on Pandemic Prevention, Preparedness and Response, the significance is that the world officially has really recognized how devastating COVID-19 was for persons with disabilities, and again, that the specific needs and requirements of persons with disabilities need to be considered in really pandemic prevention, preparedness, and especially response. And of course, these declarations build on a lot of work and a lot of advocacy that has been done towards it. It also builds on a lot of evidence, and it is recognized, the evidence that came up from the Global Report on Health Equity for Persons with Disabilities that the World Health Organization recently launched. And it builds also on to other resolutions, like a resolution that changed the agenda on disability at WHO, that is the resolution on the highest attainable standard of health for persons with disabilities. So in terms of the significance of the importance, but now let me emphasize what it means, because declarations are not legally binding documents. However, declarations and UN declarations really express the commitment of the international community. It's an expression of really what the international community is committed to. For that reason, they have a huge power in terms of advocacy tools, but also in terms of accountability tools. And accountability not only for governments, because again, is really about the global community commitment, the commitment of the global community towards, for example, universal health coverage. So we can make accountable the global community, whether it is the government, whether it is the private sector, whether it is the pharma industry, whether are donor entities, whatever it is. And I think this moral force that declarations have, and through it, then this accountability force is what needs to be used much more. Because still we need to recognize that in disability there is a huge gap between political commitment and action. It is very easy to say to disability, yes, 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 we commit to, and then there is not action. So for that reason, this declaration is absolutely fundamental to make really the global community, especially and in terms of the universal health coverage, but also in pandemic, in the one on the pandemic, really to request accountability. And just to mention in terms of the way forward, because this declaration requests the Secretary General to present a report next year on the progress that we have done in terms of universal health coverage. So it will be important to reflect, unfortunately, how little progress we have done so far in terms of addressing the barriers that persons with disabilities experience when really countries are moving towards universal health coverage. And then again, we will have the opportunity, and I think the work of the whole advocacy of disability, of the disability community will be needed for the high-level meeting on universal health coverage in 2027 that also is requested and is mentioned in the declaration. I stop there. Thank you.
Thank you, Larkos. I think really useful insights in terms of this journey, really, that this is progress is being made, but we still have a ways to go. Frederick, maybe can you add to this, bringing in the importance of primary healthcare and community-based approaches that you have experienced?
Thank you. First of all, I would like to thank you, the organizer, and specifically CBM, for inviting me to be one of the speakers in this important event. To answer the question, community-based approaches play a very crucial role in achieving the universal health coverage, and particularly to reaching people with disabilities. And I'm from the organization called Comprehensive Community-Based Rehabilitation in Tanzania that work for people with disabilities, and we have been partnering with CBM for sometimes now more than 10 years, working in the area of rehabilitation services. Now, first, community-based approaches, they make services accessible to people with disability. They bring the healthcare services closer to where people with disabilities are living. And for that, people with disabilities have the opportunity to participate in the delivery of the services, but also it helps people with disabilities to voice their needs, and their needs to be considered in planning and implementation of the service care delivery programs. And that is very, 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 very important. And it helps to address the geographical barriers and transport barriers which are facing many people with disabilities. As my colleague Eugene was saying, that we get a lot of challenges when trying to access healthcare services because of the transport facilities that are not accessible for people with disability. Another important aspect with community-based approach is that it enhances inclusion and social integration of people with disabilities in a broader society. We people with disabilities, we have this saying, nothing for us without us. Now, when we are being included in the society, we will be able as well to provide input on how the programs, healthcare programs should be designed. We can have an opportunity as well to contribute in development of the community by giving, our own talent, giving our own, inputs that can make the programs that are being implemented, particularly healthcare programs, inclusive to people with disabilities. An example from my home country, with the support from CBM, we are supporting a community-based program in the rural areas where we go and reach and identify children with disabilities and provide services to them, and we train healthcare providers on how to provide basic skills of rehab services, but also engage with the local government leaders who now they take issues of disability and include them in their local plans and ensure that the needs of people with disabilities, particularly healthcare needs, are taken into account. Another important role of community-based approach is that it allows for provision of customized support. Customized support is where the designing of healthcare programs takes into account the unique needs of people with disabilities. And for that, when you are developing, say, personalized care plan and support system, then it's designed based on the local knowledge of the community, but also on the, it gets input from people with disabilities. And for that, you create a society, I mean, you create a system whereby the interventions becomes like owned by people with disabilities themselves, and they find part and parcel of the community, and therefore enhancing inclusiveness within the society. Again, not only that, but also community-based approaches, they also help in collecting data on health care issues. When you conduct community-based outreaches, people, the healthcare providers within the local area, but even the government leaders within that particular area can help to collect data on disability, which in many cases, disability data is a challenge, and particularly in my country, even the health management information system does not capture disability data. And you cannot plan anything without having evidence on the statistics. So community-based approach is very important in terms of ensuring data is available and is used for planning and intervention. Community-based approach, they also enhance community involvement. When the community participates in the level of services within their local areas, they can also help in in terms of like providing input when they are in planning and in the implementation, but also in the evaluation of those programs. And they own the program, and then the program can be sustainable, but also they can hold into account the duty bearers to see to it that they make sure that disability inclusion is part and parcel of the service intervention programs that are being implemented. Thank you very much.
Thank you, Frederick, for these insights. And let me just ask one more question before we pass on. If you could just share briefly, Alarcos and Frederick, what change would you like to see happen in the global health community to really, truly leave no one behind? What are one or two key changes that you really think you'd want to see happen?
Okay, in the global health community, I would mention too, very often, and we see that happening in countries, but we see it also, at WHO, our colleagues, and everywhere. Very often is when one think of the needs of persons with disabilities in the health sector, or even health equity, when people think of health equity in relation to disability, they think, okay, if we provide rehabilitation services and we do something on assistive technology, the box is tick. And this conception assume that all what persons with disabilities need is rehabilitation services and assistive technology, and also assume that rehabilitation services and assistive technology is only needed by persons with disabilities. Both assumptions are wrong and are counterproductive for both agendas, because persons with disabilities need assistive technology and rehabilitation, but need access to preventive services, need access to any kind of treatment, to whether it is cancer screening, whether it is palliative care, whether it is really any sexual and reproductive health services. And then it's also counterproductive for the agenda of rehabilitation and assistive technology, because it's really make of this it takes away the universality of what those services are, rehabilitation and assistive technology. Any one of us will need rehabilitation services and assistive technology at some point of our life, and for the rest of our lives in most cases. So that is something really that I would like to see. Another wish, if I may, is the wish really that the barriers and addressing the barriers that persons with disabilities experience are at the center of health system planning. Unfortunately, disability and addressing barriers is still an afterthought. We saw that very clearly again during COVID-19. And it is really the conviction that if you would design health systems, whether it is policies, facilities, referral systems, vaccination programs, etc., really with the mind of addressing barriers that persons with disabilities experience, we could create health equity for all. So it is really health equity from the perspective of disability is the entry point for equity for all.
Thank you. Frederick, what about you? Anything particular that you really want to see change?
Yeah, I want to see change. Like, I can say I have, like, let me say 3 A's to me. The first A is affordability. Healthcare services need to be affordable to people with disability, either provided free or with low cost. And tax relief should be, administered to assistive technology, which is very important for people with disability. Affordability in terms of particularly taking example from my home country, healthcare needs of people with disabilities need to be included in the health insurance scheme. But also, affordability is about assistive technology being available, accessible, and affordable to people with disabilities. And affordability, again, is the community-based approaches should be adequately funded so that we are able to reach as many people as possible in rural areas where they are underserved. The second A is accessibility. Infrastructures of the health facilities need to be accessible to people with disabilities. You have health information and educational materials need to be packaged in such a way that our colleagues with the visual impairment and with the hearing impairment can access that information. But also, we need to have healthcare professionals who are trained on how to provide disability inclusive services to people with disability. And the last A is acceptability. Our interventions to provide healthcare to people with disabilities need to be culturally acceptable, by the community. And they should be demand-driven and not like top-down. They should be emerging from the people with disabilities who clearly understand their needs and how they should be addressed. But people with disability need to be at the center of our planning, of whatever programs that we are planning for people with disability. People with disability should be involved because they are the ones who knows much better of the challenges that they are facing, so they should be involved. But also, we need to continue improving and increasing community involvement for ownership, accountability, and sustainability. Thank you.
Great. Thank you to both of you. And I think you've heard a lot just now, a lot of ideas, a lot of things that need to change. I want us to now just take a step back and allow a short Q&A session. We will take 2 questions from the floor and then 1 question from our colleagues participating online. And we've got about 10 minutes for this session, so bear with us if we can't come to everyone's questions. We will have another second Q&A at the end. Over in the back, please.
Thank you very much for the invite. My name is Joseph Baraza from Kenya, Nairobi LVCT. I've sat and I've also had the discussions that focused on how to make things accessible, affordable for everyone. I'd like to say thank you very much for the support that you've received so far, even to attend this conference. I'd just like to add to what has been mentioned, that you have mentioned there was a declaration that was agreed, and you've also mentioned that nothing much has been done by the politicians. However, in your report, you say we have 70 million persons with disability. Are you sure? Has it also been broken down to the types of disability we have? And if not, I can say that we don't have the data that is accurate. And then I'd like to conclude with Mr. Frederick, I think, who talked about inclusivity. We need to be at the center of planning. You should never assume that the needs of a person with disability, like a deaf person, are the same ones with someone with physical disability. They are different. And also a health worker needs to be trained so that instead of using an interpreter like here, we have a conversation that has confidentiality at the center. And therefore, let the person who also has a disability sit in the technical committee, because they are the ones who are the wearers of the shoe. They are the ones who know the pain. Please don't speak on our behalf. We don't want. It's impossible for you to do that. And also the ideas that you've mentioned during COVID, I do agree that persons with disability were the last ones, especially for my type, persons who are deaf. So thank you very much also for Chai and Missing Billions to make sure that I also came here to hear for myself as a deaf person what is happening, because I do know what is on the ground. And I do feel the pain that is happening on the ground. So let's just not talk, play music. It's like playing music to me. So let's please include persons with disability in the table. That's my humble request. It's not just about talking, but it's also about us. Think about us and our future. For deaf persons, we are usually the last ones to get information. And in such a conference, please, let's work hard to make sure that we involve us.
Thank you very much. I think this was more maybe of a statement than a question, but thank you for those very full, powerful reminders. The lady here.
Thank you. Thank you very much for this insightful session. So my question is to Alarcus. You mentioned about the UHC declaration and regarding the accountability towards by all the governments, and in the UHC declaration there is a mention that 1% of the health budget should go into PHC, and when we look at people with disabilities, the services should be definitely at the PHC level and it has to be accessible. And so in this case, how can the WHO coordinate with the country offices or help to make governments accountable on that 1%? They make the 1%, and also that 1% also covers persons with disabilities and the services of persons with disabilities. And I have one question to Dr. Hildebrandt also. She mentioned about the WHS summit and towards the global inclusion of disability health services. How can she or the WHS ensure that people with disabilities are also part of the WHS planning and decision making, and we are an integral part of the summit, and and not only the session. The other sessions don't have the information accessibility as such. So how can she and the WHS work towards that? Thank you very much.
Thank you very much. Alarcus, do you want to respond to that first? And then Dr. Hildebrandt.
Yeah, thank you. Thank you so much. And also perhaps going back to the colleague from Kenya who mentioned the issue on the numbers. So I don't know where the misunderstanding came. but the data from WHO is that 1.3 billion people have significant disability worldwide. There is not always data disaggregated by the type of impairment, but for certain countries and certain settings, this data exists. In terms of the accountability, I think of governments, I think it is really, again, declarations are not binding documents, but it is really this moral force that they have. And we have heard also from Dr. Hildebrand, that is important for Germany to having been part of this declaration and also moving forward, building on it. This also creates momentum from a WHO perspective in the support that we provide to countries, because of course, countries become more aware of the need of really addressing barriers that persons with disability experience when moving forward to universal health coverage, requests also support to WHO how to move this agenda forward. And currently, for example, we have the request of 7 countries. It's not many, we need more, and advocacy again contributes to that, asking WHO for support to move the agenda forward of disability inclusion and health equity.
It's a good start.
Dr. Hildebrand, would you like to respond to that question? I think maybe you can take the microphone up here.
Thank you. I will. For the Global Disability Summit, as I said before, it will be co-hosted by the government of Jordan and the International Disability Alliance. So there will be, of course, participation of people with disabilities in the preparation and the implementation of the conference. Thank you.
We have time for one more question from the online question, I think. Miriam.
We have some online questions. Can you hear me? Yeah. To provide AT, we need healthcare facilities that can identify potential disability, refer and follow up with clients. How can healthcare services in low and middle income countries develop their facilities to meet this need?
Who would like to take this? Frederick, you want to give it a go?
Yeah, thank you. I think what is needed is actually, first, to me, I say, is the political will. And secondly, is the investment. Our government need to invest on assistive technology and make it available to people with disabilities. From my experience, assistive technology might be available, but people with disabilities themselves are not aware where it is. So we need to create awareness among people with disabilities so that they know where the technology can be accessed. And as I said, it should be affordable in terms of like cost. It shouldn't be a burden again for them to access that technology. But capacity building to healthcare professionals on AT is also crucial so that they are able to, support and train people with disabilities on how to use the assistive technology. Thanks.
Great. You want to quickly add something?
Perhaps just to mention that it is really a complex ecosystem that is not simply about putting a facility in place in a country, in a setting, and then hoping that things, that the assistive products will be available and will be delivered. So that is really a complex ecosystem that needs to be analyzed and need to be very carefully planned for sustainability. So I remain high level, not to go too much into
Thank
detail.
you. Thank you to both of you. Thanks to this panel. We will have another round of Q&A very shortly. But first, let me hand over back to Nujeen.
Thank you, Pascal. Thanks for the speakers for this very great panel and interesting question posed from our audience and the person online. Okay, for this panel, I would like to invite Director General of the Ministry of Health in Kenya, who's joining us by live video link, and in person, Professor Hannah Cooper and Dr. Vani Ping, Senior Health Advisor, Improvement on Social Protection and Health, GIZ. Professor Cooper and Dr. Ping, please join us on stage. And I hope Dr. Ahmed can hear us. Should we test it?
Dr. Ahmed, can you hear us?
Yes, I can hear you.
Okay,
oh,
perfect.
Great.
We can hear you too.
Great. Okay. For this panel, we have one overarching question. What are the concrete steps and solutions to take to make health more inclusive? And could you share what you have done differently and some lessons that you have learned in the process? I would like to start with Dr. Ahmed. Dr. Ahmed, can you please respond in reference to Kenya's rehabilitative services and assistive technology strategy? Say that 5 times fast. 2022 to 2026. To improve healthcare services for persons with disabilities and other vulnerable groups.
Thank you. Good morning, good afternoon, good evening, Excellencies, ladies and gentlemen. I want to say a special thanks to the co-chairs, Pascal and Nujeen. Again, allow me to start by thanking Etiscale and the organizers for convening this session. On behalf of the government of Kenya, I allowed this meeting as a call to action to eliminate all barriers across the health systems to make healthcare more accessible and leave no one behind in the realization of universal health coverage, particularly highlighting the needs of those in need of rehabilitative and assistive technology services, including persons with disabilities, older people, and others living with a wide array of health conditions. Indeed, we cannot talk about universal health coverage without ensuring a more robust gender, age, and disability inclusive health systems, which are fully inclusive for all. In Kenya, we are committed to positively impact the lives of persons living with disabilities through a number of proactive strategies underlined under the government's Universal Health Coverage Plan to prioritize the provision of rehabilitative and assistive technology services. First, to make health more inclusive, we developed the first ever rehabilitative services and assistive technology strategy 2022-2026, which was launched in March of 2023. The strategy aims to increase access to care up to the primary healthcare level and community levels by developing the required infrastructure, building on the human resource capacity, and providing equipment for rehabilitation. In Kenya, it is estimated that the number of persons with disabilities stands at about 3 million persons, and about 24% of the population require one form of assistive technology. That is about 12 million persons. To ensure that these services are responsive to the needs of the population, the government has also put in place a disability medical assessment and categorization guidelines to guide the appropriate and timely identification and categorization of various forms of disabilities. Further, to be able to cushion people living with disabilities from catastrophic health expenditure, the government has paid health insurance premium for a total of 2,651 households. That is a total of about 13,255 persons to ensure that they can be able to access health services. This is but just a beginning so that we can incrementally cover the remaining part of the population. Like other developing countries, we experience significant challenges in the provision of rehabilitative and assistive technology services, primarily due to the huge unmet need for assistive technologies. For instance, only 5% of the people who need wheelchairs actually access them, meaning a whole 95% require this particular AT, but they cannot be able to access it. Other challenges that still remain include inadequate human resources for health, inadequate infrastructure for rehabilitative services, as well as the high cost of assistive technologies coupled with the supply chain constraints and inadequate data for decision making. We are therefore working with partners, including AT-Scale, to address these challenges in order to enhance access to assistive technology and strengthen rehabilitative services by implementing measures including establishment of a Center of Excellence on Assistive Technology, a joint collaboration between the Ministry of Health, the WHO, and AT-Scale. We have also reviewed our essential health benefit package to ensure that rehabilitative and assistive technology services are part of the essential benefits package. We have also developed an assistive technology list, which we are going to include in the list of essential health products and technologies for rollout of universal health coverage. We are training additional human capacity in the short term and in the near medium term to be able to address the shortage of human resources for health for provision of rehabilitative and assistive technology services. For example, we have initiated a program support the delivery of quality eye health services, including screening for visual acuity in selected counties using low-key technology. And finally, we are promoting local manufacturing of assistive technology devices as part of other health products and technologies to ensure access. And as a part of bringing services closer to the people, which is one of our pillars of universal health coverage, validation of disability assessment has been recently decentralized to the 47 counties at the subnational level. Previously, assessment used to take place at the national level, inconveniencing people living with the disabilities. Further, we plan to strengthen community-based rehabilitation for early identification of disabilities and rehabilitation at the community level. Our launch of UHC, which is supposed to happen on 20th, that is Friday of this month, is premised on a primary healthcare approach, therefore with a strong emphasis of preventive and promotive healthcare. In closing, I would like to reiterate Kenya's commitment to improving healthcare services for people with disabilities and the government's concerted efforts together with other partners to increase access to rehabilitative services and assistive technology in the country, working with other partners to ensure that we leave nobody behind. I thank you.
Thank you, Dr. Ahmed. It's wonderful to have such concrete examples, which we hope other countries can follow. Over to you, Dr. Ping.
Yes, good morning, good afternoon, and good evening. Thanks for organizer that gave me this opportunity to share about our work in Cambodia, looking on social protection perspective, and this lead to improve health among persons living with disability. Before I start, let me share some country context. Cambodian total population, we are 16 million, and government estimated around 800,000 persons living with disability. So this is about 5% of total population. As you can see, there's still the issue of underestimation in terms of number, and also the situation country that we lack of data and also proper registration in order to convey in different support to the need of this target group. So Cambodian government also initiate some social assistance program in order to support the vulnerable group. Example like the Health Equity Fund, which is the mechanism that provides free healthcare to the poor population and also other vulnerable groups who are pre-identified and receiving what they call equity card in accessing free health service as well as transportation fee to reach the health facility. In addition, also government provide some social assistance support, which is just in cash, what we call this cash allowance to support population at risk. This is including person living with disability and also people suffering from post-COVID as example. So GIZ, through the support from German government, we work with different stakeholders of the government, just try to make sure that any social assistance program are more inclusive. So we start with working under beginning of targeting beneficiary of population. So we work with ID Poor program in Cambodia. ID Poor program is the pre-identification process that the method it's go from house to house just to make sure that people are included into this system. So we try to make sure that the tool will be capture the person living with disability. And also we collaborate with civil society just to make sure that to raise awareness among this target group as well through different communication channel, and just to make sure that they are aware about different social assistance support as well as service support. And beside that, we also initiate of using data application, which is try to register. We use app application to register individual person with disability with civil organization that we collaborate. And how our effort that can link social protection linked to improving health among the person living with disability, as I can say that when they are included in the target population, first they will receive free healthcare. So we're talking about a lot of barrier. I think at least we address one barrier is financial barrier, and also cover transportation fee. And then beside that, they also eligible for some other social assistance support, including cash allowance that will lead to improve their nutritional status of this target group. From this lesson learned, I can see that our government progressively improve, that they are aware about this don't leave anybody behind. So when they design, even they look back at the current social assistance program, even new design, they try to make sure that it is more inclusive. And also the experience of our data application system have been acknowledged and also adopted as a national tool. I think the last question, it's interesting that about person living with disability, they are not only need for support, for social assistance. I mean, they may need many other things, education, vocational skill training, and also employment. That's why the registration, proper registration, is very important for one government to convey the support into different needs. So from the experience, Cambodian government gradually register now. I think they cover around 25% of total this target group. And I believe that they will convey the result from registration and convey the support into different needs. Thank you.
Thank you, Dr. Peng, for sharing this valuable information and drawing from your professional experience in Tanzania. Cambodia, sorry. Yeah, okay. And last but not least, Professor Kiefer, of course.
So thank you very much. I'm sure, like me, you've been overwhelmed with information and different stories. And hopefully now you're all very committed to disability inclusion, having heard that 1 in 6 people in the world have disabilities, but because of the higher healthcare needs of people with disabilities, that will be 1 in 3 healthcare users. And that on average, people with disabilities are dying 10 to 20 years earlier. So this is an urgent matter. And improving access to healthcare is not just about rehabilitation and AT, but also about inclusive health. So the question is, what do we do? And we've also heard stories from individuals, for instance, from Barbara talking about consent. Do we tackle consent? Do we tackle AT? Do we tackle accessibility? Where do we start? And with the missing billion, we've tried to break down this very complex, which can seem overwhelming issue into building blocks to address. And that can help set a structure for what we do, but also acknowledges that countries are different. Countries will have different needs and will be at different journeys in their inclusive health provision. And that this is an issue not just in low middle income countries, but in high income countries, who can also and must also do more to make their health services inclusive. So within the missing billion, we've taken the concept that health systems must expect people with disabilities, accept them and connect them. And to be able to do that, we've drawn out a system framework of building blocks that are needed. So from the systems level, there needs to be good governance in place, but as has been pointed out, just having those governance and policies aren't enough. There must be action. There needs to be leadership, there needs to be financing, and then my favorite as an epidemiologist, there must be data and evidence. And with that, that can drive changes for the healthcare workforce. So healthcare workforce is trained, that the facilities are accessible, and that rehabilitation and AT are available. And for people with disabilities, the services must be affordable and that there must be awareness. And so what we've done is made a framework so that health systems can assess where they are and then prioritize what the greatest need is for that country, to try to not have a huge laundry list of things that they must do, which seems overwhelming, but agree a few priorities. And we've been working in partnership also with McKinsey to start that work in different countries. And so sometimes it's going to be training healthcare workers, which will be the priority. And other times it's going to be things like addressing the affordability and improving that safety network from a health insurance perspective. And I think the other thing that we've heard today is examples of what works, and they can be very inspiring. So it can be very specific ones like social protection in Cambodia, but also like in Kenya, where we heard holistic things that are being tackled to try and improve inclusion. And the other thing that we're doing within the missing billion is to start highlighting those good practices, documenting them and sharing them, so it can become inspiration for others, but also examples of what can be done. Because hopefully we've all become aware now of this issue, but then there's a question of what do I do, what can we do, and what is the evidence for where to start. So we've developed these system-level assessment tools to look at governments and then prioritize, but also looking specifically in facilities to see where the facilities are with respect to accessibility and to allow facilities to start improving themselves. And as was mentioned earlier, it's very important, this idea, this fundamental principle of nothing about us without us. And within all of these actions, there must and will always be partnership with people with disability to ensure that the decisions made are appropriate, that they're attracting the right solutions and are inclusive. Now, why I think it's so important to have this kind of structure is because otherwise we can be led very much by lobbying or being pulled in different ways rather than the evidence of what the greatest need is and what works the best. And so I really believe in this evidence-based approach, and if you're interested, we've also written a report which I think is available outside. So I'll just leave you with a little bit about where we are with this process. So with the missing billion, as I mentioned, we've partnered with McKinsey to develop these tools, but we've also just made a commitment at the Clinton Global Initiative also with the International Disability Alliance and CHI and the London School of Hygiene, to really start to work in 10 countries to identify what the needs are and implement changes. And we really call everybody here, anybody who wants to collaborate or join us on this journey in any way, to join this collective action, because although there's nothing about us without us with the disability movement, this is also a collective call that we really need all global health actors to join this and see disability not as a minority issue, but as something that affects very, very many people. But also, as Alarkas pointed out, if we build health systems to be inclusive of people with disabilities through these mechanisms, then they'll work better for everybody. Thank you.
Thank you, Professor Cooper, for sharing the best practices, which we can hope to see implemented everywhere in the future. Thank you to all our panelists, and now it's time for our second Q&A. Just like before, we will take 2 questions from the panel and 1 from our audience online. Please do, our audience online, please don't forget to use the Mentimeter to answer the questions. The code is 7166 4021. By the way, you have the best handwriting ever, Pascal. Okay. And please raise your hand. Don't be shy.
Okay. Good morning. My name is Ayobami Afakwe. I'm from Nigeria, and I'm an advocate for UHC. In the last year, I worked with the government in my country, and one of the questions I always ask is sustainable financing for UHC. How do we get it? For example, Nigeria, we have about 10% people living with disability. That's about 20 million people. And the funding to ensure that these people have access to care is very questionable. And the ownership and sustainability of this funding is at risk in sub-Saharan African countries because our governments are not ready to release funding to ensure that these people have access to care. My question is directly to the director from Kenya. How do we ensure sustainable financing for UHC in sub-Saharan Africa? Because without money, we cannot ensure that everybody have access to care. How do we ensure sustainable financing for UHC? Thank you.
Wait, maybe we should. Dr. Amot, would you like to respond? Sorry, you might be on mute. Can't hear. We can't hear you, Dr. Amot.
I can hear you.
Okay, we can hear you now.
Okay, thank you. Thanks for that question. And financing, of course, is one of the key pillars of universal health coverage. And we are in difficult moments as at now because of tight fiscal space, because of the economic dynamics of the current world. So countries have to make deliberate attempts to ensure sustainable financing for universal health coverage. I will talk from the Kenyan perspective, where we have prioritized our journey towards universal health coverage based on a primary health approach with a strong community services component. What we are trying to do is to ensure that we bring services closer to the people as much as possible. But the other thing that we are doing to ensure sustainability, of course, is to drive our agenda towards social health insurance, trying to focus on the vulnerable and marginalized members of the community to ensure that we make deliberate attempts to ensure that they have financial protection and they can be able to access health services. We have done an assessment of Kenyans who live with disability, and therefore these are the people we are going to prioritize first to ensure that they receive cover under the National Health Insurance Fund. However, countries must also work deliberately with other institutions, including the National Treasury, the Ministry of Finance, the civil society, to ensure that we increase our portion of the budget towards health. And once we receive that portion, then we need to prioritize and start with the poor, the vulnerable, and the marginalized to ensure that they can be able to access services. Otherwise, this will require each country to be able to develop sustainable financing within its own context. Us as Kenyans, we have tried to prioritize the poor, the vulnerable, and the marginalized to be able to receive care from the government. We have also gone ahead to be able to collect data and do what we call means testing, because our economy is basically 15 to 20% formal and 85% informal. How do we ensure that those people who are in the informal economy and can be able to pay for their health insurance then are brought on board? Very many angles or very many prongs to approach, but for us, it's basically trying to build a resilient healthcare systems based on a primary health care approach with comprehensive integrated healthcare services as close as possible to the people. Thank you.
All right. Hello, everyone. I am David Duncan, a health messenger from Special Olympics Jamaica. I'd like to start off by saying I'm very happy that the Disabilities Group has been able to host this session here today. My question is, with all the information being collected and all the advantages made in assistive technology and other medical areas, how can we ensure that persons like me with an intellectual disability and with other disabilities has the confidence to come forward, to be registered, to take part in all the medical strategies that are involved, and to let people know that we are disabled and we would like the help? Because as in Barbara's situation, she went to the doctor and she received the wrong medication without her will. I find that most times persons with disabilities, because of the stigma being attached to them and because of the treatment, they don't want to come forward with their disabilities, and some of them do, but their families and their communities try to hold them back, or their persons don't believe that they really have a disability. They see it as a behavioral disorder, or that they're being mischievous or something. So can we ensure that on a personal level, that persons with disability will have the confidence to come forward and take part? Because if they don't, then all the numbers and the data being collected will be incorrect, and you won't have the reach that you want to have globally. So these persons will still be left out. That's my question. Thank you.
Yes, thank you for question. Let me try to answer some of this question. Yeah, information confidentiality is very important. And then when we start to use our data application in Cambodia, also we look about, first we look about any software program that will be reliable and more confidentiality. And in general, most of the country, they collect information about the limitation of individual person, and they call the Washington tool, which is not more on the discriminate really specific disability, but look on the point of view how limitation of individual person in terms of seeing, in terms of walking, in terms of other things. And I think in generally in most of the country, including Cambodia, where I'm coming from, discrimination is also one of the barrier and issue as well. So what we try to do, I think first thing that is related to sustainability as well. First thing we need to do with the healthcare provider as well. We need to train them about disability right, to raise awareness among the healthcare provider first. And I think gradually they will understand about different needs and also a special need of services for this target group. Yeah, nothing perfect, but at least we can address some of the issue. Thank you.
Kim? No, I don't think we have time for another question. Sorry.
Okay.
Sorry, I do think that we are going to have to be wrapping up very soon. So we'll have to stop the question and answers now. But you know, our panelists are still around, and also those who spoke earlier are still going to be around right after this session if you'd like to come and speak with them. As we close, maybe Eugene and I can just share a couple of takeaways from what we heard this morning, and then we will ask you to also do likewise through the Mentimeter. So don't go anywhere just yet. But Nujeen, any reflections from what you've heard?
I think the point that I got is that no single country in the world can say that they have universal health coverage until they include disability. And if they actually state that and say that, you'll have to ask them about it. And until that becomes a reality, then the mission is still underway and it's not yet completed. So over to you.
I think you have nailed it on the head, Nujeen, in terms of the key takeaway. Maybe just to add a few other things that I heard. I think I found very powerful some of the personal testimonials and the importance of self-advocacy. Right? We need to help and support and work with people who are living with disabilities and others who need assistance or technical assistive technology, to really be their own strongest advocates. We also heard, I think, clear messages around the need to have really comprehensive approaches, and it's not just about providing one product or one service. It's really an entire spectrum of services that is needed end to end within primary healthcare. We also heard a lot about data and challenges around data. We know there's massive inequity, right? And it really is a moral imperative that we have to address this issue that only 10% of people who need assistive technology, for example, have it in low-income countries. But we really do need better data to prioritize and target all of these efforts. Financing came up on a number of occasions as well this morning, I think, and working towards sustainable financing mechanisms like social health insurance, like what Kenya and other countries are trying to put in place. And I do believe that the international community also, I think, and maybe this hasn't come up, but I will say it, but the international community and donors and official development assistance has a role to play in this as well, to work with and support governments in lower and middle income countries to help put in place these sustainable mechanisms. And not enough today is done from the international perspective. Last but not least, it's a collective effort. We're all in this together. It concerns everyone, as we've heard, right? It's also people who are getting older. It's really, truly everyone should be concerned by this. And so let's all come together, build on this momentum, and hopefully see you next year with a lot of progress to be spoken about and hopefully in the plenary room. Thank you.